Good morning and welcome to another Insight AppSide webinar. My name is James, one of the clinical educators here with Insight, and we'd like to begin this morning by acknowledging the traditional owners of the lands on which we're meeting here in Brisbane today and learning on where you are. I'd like to acknowledge the elders past, present and emerging, and also extend that respect and acknowledgement to any Aboriginal and Torres Strait Islander people who might be joining us in the room here today at Byalla or out there in webinar land. So thank you again for tuning in. We have, I think, a very significant and important conversation that we're having today through the presentation, the role of substance use in family and domestic violence. And we're very privileged to be joined by a group of learned professionals and researchers in this field, Dr. Rochelle Mayshak, Dr. Ashley Curtis, Dr. David Skvarc, and Mr. Trevor Harries. And they're from, as you can see on your screen there, the Centre for Drug Use, Addictive and Antisocial Behaviour Research, which is part of the Deakin School of Psychology. So without too much further ado, I'll introduce our first speaker, Dr. Rochelle Mayshak, in a few moments, but just to let you know, for anyone who has joined us, we will be taking questions throughout the presentation this morning, and towards the end we'll have an opportunity to put as many of those as possible from the room here at Byalla or for anyone out there in webinar land to our presenters. And I apologise in advance if we don't get through all of those in the time that we have. But without any further ado, Rochelle, I'll hand over to you and allow you to take us forward. Thank you.
Thanks for that. We're so pleased to be here today. So thank you again for inviting us. We're really happy to come along and talk about our research and our understanding of this really complex and difficult area. We'll get into it. Again, thank you for joining us this morning. We're going to talk about some of the more recent research around family violence and substance use. I'm Dr. Rochelle Mayshak. I'm a researcher and a lecturer in Deakin University School of Psychology. And I'm joined today by Dr. Ashley Curtis, who has quite a bit of experience working with organisations who support families. So she's going to bring some more practical application of the research. Dr. Dave Skvarc, who knows more about the brain and cognitive psychology than I will ever know in my life. And our PhD candidate, Travis Harries, who is just about to launch the recruitment of his first study into child-to-parent violence. So I'm really excited to be here today. Also got a little bit of a cold. I think my daughter brought something home from daycare yesterday just because she knew I was coming today. So I do have tea that I'm going to sip periodically to try not to cough everywhere. Over the next hour, we are going to talk a little bit about first some statistics from some research that we ran a couple of years ago. Dave will cover the links between substance use and aggressive behaviour. Travis is going to talk about the different theoretical models of violence. And then, as I said, Ashley, with her practical knowledge, is going to be discussing the best practice interventions and the practical implications of the research. So in Australia, what we know from the research is that 1 in 4 women and 1 in 13 men have experienced some kind of intimate partner violence, with over half of these people reporting it as a recurrent issue. These statistics are similar to those seen in other countries, so it's far from being limited to just an issue in Australia, as we obviously know. Family and domestic violence can include physical, sexual, psychological, emotional, verbal, social, economic, and spiritual abuse. It is a full wide gamut of different ways that people can have a really negative impact on those closest to them, whether it's family or romantic relationships. It can range from mild threats to severe abusive acts. It can also occur as an isolated incident or over an extended period of time. The one thing we know about FDV is that it's different for everyone and it has a wide range of impacts on victims and their families. So it's not just an isolated one-off incident. It's not something that people immediately recover from. It's something that can have really long and wide-lasting impacts. Rates of FDV are higher for women, for Indigenous people, for young adults, for disabled people, and this is why we're here today, it's also higher in those who have some sort of problematic alcohol or substance use behaviour, whether it's the partner or the person who is unfortunately a victim. The two main forms of FDV that we generally refer to in our research are intimate partner violence, which is typically between those who are in a romantic relationship of some kind, and family violence, which includes any other family members. We're also seeing a lot more incidents of coercive controlling behaviour, which you can see on my slides, which can occur alongside any other type of violence, or they can just occur on their own. Coercive controlling behaviours are considered to be non-physical forms of FDV and are characterised by recurrent attempts by one partner to belittle, to intimidate, to isolate, or to otherwise gain some sort of control over the other person. It's insidious and it's typically covert. It's something that on the outside people don't really see until you start talking to the person and you realise that they are being sort of broken down very slowly over time. It can often escalate over time as well, and it can lead to fear, it can lead to entrapment and dependence, and often the victim feels quite reluctant to leave the relationship because of that power and control. They feel like they've potentially done something wrong, or that things would be worse if they ended up leaving. So when you consider coercive controlling behaviours in the context of general domestic violence as well, you can see why people would be severely affected, that it's sort of an ongoing emotional abuse on top of that potential physical abuse that's occurring at the same time. One of the harder stats that we've come across is that those who have experienced coercive controlling behaviour have a higher likelihood of engaging in self-harm. They also have an increased rate of substance abuse, depression, and anxiety symptoms. The final definition that I wanted to touch on very briefly here is around child-to-parent violence as well. It obviously falls under the category of family violence, but it can manifest in different ways as well. We might see verbal, physical, or psychological violence from young girls and young boys towards their parents or their caregivers, or it could be teenagers engaging in family violence. But we might also see adult children offending against their parents or their caregivers. So again, it can have a really wide range of different impacts on families when children decide to offend against their family. The statistics around this are increasing, with more families reporting incidences of child-to-parent violence, especially after last year with our lengthy lockdowns and changes to family dynamics, especially with kids doing things like homeschooling and just being around the families more often. As we move through the statistics on the next couple of slides, it's important to keep in mind the long-reaching impact of family and domestic violence on the community. It's also really important to note that while our focus today is on substance use, that this isn't obviously the only contributing factor. There are so many interconnected, complex contributing factors to whether or not someone will be involved in family violence. The key thing about substance use, though, is that it's a modifiable one. It's something that as a community, as clinicians, as professionals, we can do something about it. So that's kind of like my little bit of hopeful, my little seed of hope that I really want you to hold on to as we're going through these statistics. So I'm going to start with some numbers from a report that I was really lucky enough to work on a few years ago. It was the Alcohol and Drug Involved Family Violence in Australia, or ADIVA project, that was led by my colleague, or our colleague, Professor Peter Miller, who you may have heard of, and he's at Deakin University with us. What we did was we analysed police-reported domestic violence incidences across the country. This was a huge undertaking. Some of the data files were so big that we couldn't even open them. We had to get supercomputers just to open up the data files because there were so many incidences. But it allowed us to do something that hadn't been done before, and that was create a number of models predicting the incidences or the different correlates of domestic violence between 2009 and 2015 across each state. If you're interested in reading the lengthy report, I think it's about 600 pages, just on your nightstand. I have added the reference at the bottom of this slide, so please have a look. But ultimately, the key thing that we found, and you'll see already on this slide, is that when we just looked at something like the illicit drug flag, there wasn't sort of too much happening in terms of illicit drugs. Before I go into the numbers too much though, I'll just pause to note that the literature does suggest that more than 60% of family and domestic violence is completely unreported to police. So the data that we have is likely to be underestimating what's actually happening. It's also a reasonable assumption that people might be less willing to report an incident if there are illicit drugs involved, due to fear of further negative consequences or experiences. So I think these numbers are a good starting point, but they're obviously not the bigger picture. They're not what's actually going on in terms of the sort of the number of incidences involving illicit drugs. So depending on the state, as obviously each state had a different procedure for recording the illicit drugs and flagging it, we saw a relatively low proportion of FDV incidences that included the flag. Interestingly though, when we look at the relationship between illicit drugs and other factors, we found that children and other family were significantly more likely to witness those drug-related incidences. We also found that offenders were more likely to be repeat offenders if drugs were involved. And additionally, from a community survey that we did at the same time, we found that IPV incidences involving drugs were more likely to involve physical violence and to result in physical and psychological injury. So obviously, what we were seeing there was that illicit drugs were really adding another layer of complexity and another layer of almost harm to the victim and to the situation. Looking at the alcohol flag across states, we can see that between 2019 and 2015, around a quarter to almost half of all incidences were alcohol related. Now, for most states, we had this information for both perpetrators and for victims, but in South Australia, we only had the alcohol involvement recorded for victims. Across the states, the general theme, and again, this sort of has to be taken under the context of each state records things so differently. So we couldn't just throw it all into a big Australia-wide data set. We had to keep it separate. Across the states, so the general themes that we were picking up on was that alcohol use at an incident tended to be associated with people who were repeat offenders. There was usually illicit drug involvement as well, usually repeat victimization, and the offences were generally occurring in more socially disadvantaged areas if there was alcohol involved. The one mildly positive, and I know there's a better word for that, statistic that came across in most states was that the presence of alcohol actually seemed to decrease the likelihood that children were involved as either the victim or the witness, because that was one of the other flags that we could see in the data too. So while it wasn't necessarily a protective factor, it did just seem that if people were drinking and getting into really, intense arguments, that it did seem that the children weren't home or were off somewhere else at that point. Across time, we do see similar increases in rates per 10,000 people across each state as well. However, between the 2009 and 2015, we did see a little bit of a decrease in New South Wales and Tasmania. There are a number of new policy changes that have come into place since 2015 though, because obviously that's a few years ago. So we're going to hopefully start seeing these rates decreasing a lot faster. Now, I don't want to linger on the gender issue too much because we are going to talk about it a little bit later, and it is a big one. But the general literature does suggest to us that substance use, gender, and family and domestic violence do seem to be related in some way. The general stats are, so if we look at perpetration of family and domestic violence, typically, if alcohol is involved, then it's about, it's 6.24 times higher to have that perpetration if alcohol use is involved. We also see stats coming out like males with substance use problems are usually 4.66 times more likely to perpetrate family violence than those without substance use problems. And males and females appear to be about 3.7 times more likely to be a victim of family violence if they have a substance use problem compared to those who don't. So again, alcohol and substance and other substances are really adding that extra layer of complexity. Now, I can probably feel my colleagues already yelling down the screen saying, all right, Rochelle, you've talked enough, time to let someone else say something. So I'm going to finish on this slide here. The purpose of all of these stats is really to provide a general understanding of the proportion of our community who have experienced drug or alcohol related family violence. It's not to put the blame on anyone, obviously, for consuming alcohol or drugs, but it does give us a better understanding of the contributing and the modifiable factors that can lead to a violent incident. It's also important to note that relationships are complex and they're ever changing. And a simple data point doesn't really tell us the story about why a couple's staying together, even after repeated FDV incidences. We know from the literature that alcohol and other drug use is associated with higher rates of FDV. It's increased with, it's involved with increased severity of that FDV as well. Also, there's an increased likely of it being involved in like a sexual assault at the same time. Physical assaults have also been found to increase tenfold when any alcohol has been consumed. Further, and really concerning, is that approximately half of our IPV homicides in Australia appear to be alcohol related. So alcohol is having that extra contributing factor. And I feel like I'm just saying the same thing. Before I hand over to Dave to talk about some of the neurological science behind aggression, I wanted to pause on this quote on the screen from a colleague who works with families who have experienced FDV. She says that arguments are normal in most relationships, and in the more difficult ones, the tendency to be violent is there, but it's the alcohol that brings it out. Alcohol lowers our inhibitions, it amplifies our underlying frustrations, and has a tendency to trigger violent outbursts that may have otherwise been avoided. Okay, thanks everyone. Over to Dave.
Okay, thank you, Rochelle. Well done. So good morning, everyone. My name is Dave Skvarc. I'm also a researcher at Deakin University in Geelong. And so what I would like to do is take you through a little bit of how we understand the relationship between substance use and aggressive behaviours. Now, to really understand how substance use can be associated with aggressive behaviours, we need to start by explaining the function of certain parts of the brain and how they all work together. So the brain is essentially just a big network of things that are turning each other on or turning each other off, or up or down. Now, different parts of the brain are responsible for different functions, and a useful way of thinking about this is that the further into the center of the brain, towards what we call the brain stem and the hindbrain, the more basic or life-critical these functions become. So, for example, the organs in the brain that are around the brainstem, which is sort of just behind the top of your neck or the back of your neck area, this is responsible for controlling things like our heart rate, our breathing, and all sorts of survival reflexes. So basically anything that we take for granted as an automatic response. So the classic example of this is when we touch, say, a hot stove and then we instinctively pull our hand away, this is a reflex that actually comes from the brainstem itself, and this occurs without any conscious input. So that automatic reaction happens deep within our brain. Now, one brain structure is called the limbic system, and this is typically responsible for what is famously known as the fight or flight response that I'm sure you've probably heard of. And this occurs in response to environmental stresses and triggers the production of adrenaline in order to prepare us for action, either to obviously start fighting for our lives or start running for our lives. Now, the triggering of the fight or flight response is a fairly automatic process. And what we mean by fairly automatic is that it happens at the start outside of our conscious control. Now, the continuation of adrenaline, so once the adrenaline starts, the continuation of that adrenaline is governed by what we call higher order brain structures that are able to implement some degree of control over those lower order mechanisms. So if we think about this as the functions of brain organs become more automatic, the deeper we go into the brain, the further away from the skull, then on the flip side, the further we go towards the skull, functions requiring greater conscious control occur in those functions, or those structures rather, just below the surface. So for example, while the hindbrain controls the basic motor function of things like breathing, such as expanding the lungs and opening up the throat, those sorts of things, and the limbic system might trigger adrenaline to increase our breathing rate, we can, to some degree, begin to exert some degree of conscious control over this if we so choose. So for example, we might begin consciously trying to slow down our breathing in response to noticing that our heart rate is rapidly increasing, for example. We might start taking deeper breaths in order to try and manually calm ourselves down. Now, that conscious or manual control over slowing our breath rate has a sort of feedback system within our brain that starts sending signals to that limbic system and then subsequently deeper into the brain to start tapering off that fight or flight response. And as such, you can see how the brain structures begin to work together to react to the environment through a mixture of what we call those automatic or even instinctual activities and actions, as opposed to those conscious or manual control actions. Now, the brain structure that's right behind the front of the skull, so just behind your forehead, this is responsible for a great deal of this conscious control. And this area that we usually refer to as the frontal lobe, which you can see on the slide there, this is responsible for cognitive processes such as decision-making, making plans, evaluating risks, understanding rules, so even social rules like, do I wait in a queue or not, those sorts of things. And typically what we refer to them all is this idea of inhibitory control. Now, because those sorts of processes are used in the governing of lower order processes, so when we say we start at the top of the brain and we govern lower, deeper order functions, we usually refer to those cluster of functions as this thing called executive function. So if you think of the executive of a company, same sort of thing here. Now, as executive function is centralized into those frontal lobes, injuries that occur in that region in the brain reduce the overall level of executive function that any individual has, and then subsequently reduces the amount of conscious control an individual has over any of those automatic or even, as you might say, impulsive actions. So for example, an individual with a frontal lobe dysfunction because of, say, let's say they had an accident or there was a traumatic brain injury or something happened, we may start to notice that they begin acting more impulsively than they had to prior to their injury. Now, we also know that substance use can also impact frontal lobe function either through chronic damage or even in cases of acute intoxication. Okay, and next slide, please, whoever is in control. Thank you. So now we get to aggressive behavior. Now, aggressive behavior, particularly what we refer to as retaliatory aggressive behavior, is strongly predicted by impulsivity and the ability of an individual to manage sudden, emergent impulses. So retaliatory responses to a perceived attack or an insult, so even something as minor as someone bumps into us on the street, or we're working in a shop and someone starts shouting at us over the shop counter, or we notice that someone cuts us off in traffic and they're driving in an unsafe manner, this will trigger that adrenergic fight or flight response. And as we know, these are a deeply automatic reaction that have to be curtailed manually by us. So these are things that we have to say, no, I can't just jump this counter and attack someone. There's consequences to those actions. Now, that ability to consciously control those impulses, as we touched on earlier, this is referred to as an inhibitory control mechanism. We actually control our inhibitions. We are able to inhibit those impulses. Now, chronic substance use reduces the effectiveness of the frontal lobe structures and then in turn reduces that level of inhibitory control that an individual has. We also see the same thing in acute levels of intoxication, although what we also tend to find is that in more acute levels, so someone who hasn't had that chronic level of substance use, the acute damage to inhibitory control typically returns to usual levels once intoxication has diminished and sobriety has resumed. In alcohol more specifically, we can also see this phenomenon of what we call alcohol myopia, which is where intoxicated individuals tend to focus on things that are immediate to them. They see the short-term immediate stimuli and events, and they lose focus on longer-term issues. And this is why we start to see things like people overreacting immediately to perceived insults without consideration of any potential longer-term consequences, be they social consequences, financial, judicial, whatever they happen to be. Now, interestingly, the relationship between conscious cognitive control and substance use is to some degree self-perpetuating. It's not just a straightforward one-to-one. Now, substance use is itself predicted by lower levels of inhibitory control. So people who naturally have lower levels of inhibitory control are more likely to use substance use in general. And executive functions themselves are strongly predictive of general cognitive function. Now, what this means is that for things like interventions that might require high degrees of cognitive control, so for example, something like cognitive behavioral therapy, CBT, those sorts of things, individuals in whom those processes are already diminished, they may not actually be able to participate effectively enough in their own treatment in order to experience benefits. Okay, thank you very much. I think that's mine.
Thank you, David. So one of the ways that we can conceptualize the role of substance use in family and domestic violence is to take a step back and then consider its impact within some broader theories of violence rather than focusing on these purely biological elements that Dave has just gone through. Now, there are many of these theories, but one of the more prevailing models of violence and just problematic behavior more generally is the I-cubed model. And this model revolves around the impact of 3 different types of influential factors, which will either increase or then decrease the risk of violence being used, or the severity of that violence if it is being used. And these are instigating factors, these are impelling factors, and inhibiting factors. So in instigating factors, first off, these are situational occurrences or events which then present the opportunity for an aggressive response. So regarding general aggression, this could be a provocation from another individual. So as Dave mentioned before, bumping into someone in the street, which then affords or creates a situation where aggression could be used or can be used. So for intimate partner violence, more specifically, this could be something like the use of aversive or defensive language from a partner, which we know is 2 times as frequent in aggressive relationships. And it provides that opportunity for an escalation to physical violence. Impelling factors are usually historical or temperamental factors, which then increase the likelihood that that individual will respond to the instigating factor with violence. So for example, intimate partner violence is more frequent in those who have or already have underlying relationship dissatisfaction. Alternatively, person-level traits can also impel aggression. So we know that for individuals who use substances, having antisocial traits or experiencing a mental health issue both raise the likelihood that they'll respond to that instigating factor with violence or intimate partner violence. One of the strongest impelling factors, though, again, for those that use substances, is having experienced abuse as a child. So the experience can, in some cases, increase the chances of future IPV by up to 12 times compared to those who use substances but don't have this adverse childhood experience. So that's a really strong predictor or impelling factor in this case. Inhibiting factors work against the influence of our impelling factors, and they reduce the likelihood of aggression. So for example, again, as Dave introduced, having healthy executive function and control over impulses is an important inhibiting factor for violence. For substance use generally and substance-related aggression more specifically, we know that neurocognitive dysfunction is pretty common. It's a common comorbidity, and it increases the likelihood of violence for these individuals by disinhibiting those impellents or those impelling factors towards aggressive responses. Within this I-cubed model, serious and severe violence occurs in the event of what we call a perfect storm. And this is pretty straightforward. If the instigating factor is strong, so there's a strong provocation, impelling factors are also strong, and inhibition is weak, then violence is likely, and particularly severe violence. However, if just one of these factors is mitigated, the severity or the risk of violence is then reduced. And this is where the impact of substance use can be very important, where you can clearly see its impact. So in relationships where substance use is not occurring, even if there is conflict, so there's the opportunity for aggression, and even if one partner, say, has a history of violence, so there's impellence towards violence, towards an aggressive response, inhibition can remain high and then offset the severity or offset the risk for intimate partner violence. However, if all the factors are the same, but with the introduction of substance use, which creates that weaker inhibition, then we have a perfect storm for violence in relationships. So I guess the take home here is that substance use is an important consideration in the likelihood of family violence occurring, but only in the context of other factors. There's a whole lot of interaction with instigating, with impelling factors that needs to occur beforehand. Next slide, please. Thank you. So this IQ model is very good at explaining how violence occurs in high conflict relationships where violence is usually bidirectional or it's situational. However, we do know that intimate partner violence can, in fewer cases, be gendered, and it can be entrenched within these attitudes of male dominance and hostile sexism. And these cases usually involve male perpetrators, and they occur alongside those patterns of coercive control, which Rochelle outlined at the beginning. Substance use can also play a role in this form of intimate partner violence as well, though it can look a little different, and the impact here goes beyond the physiologically, behaviorally disinhibiting effects of alcohol. So at a very basic level, we see that males with less equitable gender attitudes who also use alcohol have a far higher likelihood of using violence over and above what the individual increase in risk would be for either of those factors in isolation or individually. And it's likely that substance use can exacerbate some of these control dynamics in relationships. So specifically, research has demonstrated that alcohol tends to heighten frustrations around a female partner's failure to fulfill household activities. So making it more likely that these perceived indiscretions, for lack of a better phrase, will then eventuate into violence. Substance use can also provide its own opportunity for leverage or control in a relationship as well. So, for example, males who engage in violence in a relationship where both partners use substances, they're sometimes reported to monitor access to these substances or control the access to these substances as a means of broader control over their partner, to use it in a coercive way. Moving away from partner violence now, family violence perpetrated by a young person or child to parent violence is also a unique consideration when it comes to how substance use is implicated. And again, the effects here do stray from purely myopic considerations. So of course, we know that being under the influence will increase the likelihood of adolescent family violence in the same way that it does for intimate partner violence. However, at this age, young people often use substances with their peers, not with their family, and it's somewhat hidden from the household. And so because of this, the rates at which young people or the young person is actually under the influence when they're being violent is pretty low. It's only around 27% of forensic cases, which leaves a whole lot of other very serious cases of abuse where the young person isn't reported to be under the influence of any substances. Instead, the young person's substance use may actually create stress for parents. They then try to intervene or confront the young person about it, and then the subsequent conflict that's created by this leads to violence, so they fall into those coercive patterns. Alternatively, though, some escalations to violence may happen when the young person requests money for substances or is actually returning home from being with their peers, and they're coming down from the effects of the substance, which would lower their inhibition. Regarding the parents' substance use, there's some mixed evidence here, but what we can gather is that mothers who use substances are at a 70% greater risk of experiencing physical abuse from their children, whereas fathers seem to not be at any greater risk whether they use substances or not. And the reasons for this at this stage, unfortunately, are very much unclear, and that's the nature of the research in this space. But moving forward, we hope to clarify that. I'll hand over to Ash now to talk more about risk and intervention.
Thank you, Travis. So Travis mentioned some of the risk factors when talking about the I-cubed model that have been identified in substance-related family and domestic violence. But I will just touch on a few others, and I am aware of the time, so I will possibly fly through some of this a little bit, but I'll spend some more time on some of the later slides. But we can see there are some relationship factors that play a role. So that's things like the belief that there's a link between alcohol and relationships. So females who use violence against their partners had a greater belief that their drinking caused their relationship problem, but their relationship problems caused them to drink. And then violence plays a role in that as well. So financial stress also plays a role in relationship factors that lead towards violence. We've got demographic factors as well. So males are twice as likely to perpetrate family violence if they're unemployed and use alcohol or other drugs, whereas females are actually twice as likely to be victims if they are unemployed and use alcohol and other drugs. Touching on something Rochelle mentioned earlier around children. So the literature tells us that for every additional child, perpetration of violence in a relationship by males or females decreases. And as education increases, we know that perpetration decreases as well. We know in terms of individual factors that a history of violence and a history of arrests and antisocial behaviour more generally results in a higher level of perpetration of family and domestic violence when there's alcohol and other drugs involved. Might jump to the next slide, please, Rochelle. Thank you. So I just want to touch on some of the intervention options that are available for this population. And this is based on a lit review that was done a couple of years ago. So, you know, there could be some newer, more emergent interventions that aren't necessarily covered here, but the ones I'm going to talk about are Duluth programs, or we typically refer to those programs in Australia as men's behaviour change. And Duluth model has been really commonly used in the family violence field. It's really prominent for about the past 30 years. And it's a psychoeducational program with the goal of holding the perpetrator accountable, but also confronting gender power imbalances and modelling equality. So in these kinds of groups, group facilitators typically identify and challenge behaviours. They model alternative, more positive behaviours and solutions to conflict as well. And these are usually large groups where there's a peer-supported approach as well. Research hasn't been overly supportive of this type of intervention, just from an evaluation perspective. So it tends to find that the effects of this kind of program are minimal, even when the studies are done really well. And alternatively, a lot of the studies haven't been done very well. So we don't really have a lot of evidence to support this kind of either way, but it is very commonly used in Australia. And I'm sure you've all heard of these programs, or know of these programs in one way or another. One of the key issues with this kind of program in terms of substance use and family and domestic violence is that people traditionally, or in the past, who have had substance use problems have been excluded from men's behaviour change or Duluth style programs because it's seen as a factor that would impede positive outcomes. And so even in New South Wales, for example, there's a best practice guidelines for men's behaviour change, and that talks about making sure people are referred to substance use treatment, and the substance use is addressed concurrently. So it's not something that's necessarily addressed in this men's behaviour change program. Now, we've also got cognitive behavioural therapies that have been used in this space, and these are skill-based. They tend to focus on treating violent behaviour as learned, something that's been learned through past reinforcement of observed behaviours. The literature is not, again, very supportive of CBT in this space, but it has been suggested that when you combine CBT with motivational interviewing or some motivational component, then it is likely to be slightly more effective, or if you combine it with something that addresses the comorbidity. So if you combined the CBT focus on violence with, say, the focus on substance use, that would be more likely to have a greater impact than just focusing on one or the other alone. There's Motivational interviewing, as I just mentioned, this has been found to be quite effective as a pre-intervention component. So not necessarily as a treatment on its own, but sort of having it first before somebody enters into treatment has been found to increase engagement, session attendance, compliance. And so that can have a really important impact for keeping people involved in intervention, which is often the biggest struggle. We know we can use substance use interventions in this space. So just focusing on the substance use and not addressing the violence at all. This can have an impact. It's not as strong as when you address both necessarily, but it does have an impact, which just again highlights how important substance use is in this behavior. If it's having an impact by itself when it's reduced, that tells us it's a pretty important factor that we need to be considering. The next one is relationship interventions. Now, this is a really controversial space in the family and domestic violence field. But what we do know is that interventions like behavioural couples therapy, or BCT, which is a couples approach used to treat substance use problems, actually can have an impact on family and domestic violence. So by addressing the relationship problems and the substance use, it actually can impact on relationship conflict. It can impact on, of course, the substance use, which are both risk factors for aggression. So if we reduce those things, then we reduce the likelihood of intimate partner violence. And couples therapy also works on improving the positive things in the relationship. So spending more time together, increasing positive feelings, both of which are going to have a positive impact on aggressive and violent behaviour. Importantly, couples therapy really works on skills that are known to be involved in violence. So communication skills, emotion regulation skills, those are really key, problem solving skills, really key skills to having an effective and positive relationship. The integrated substance use and violence interventions, that's sort of a relatively new space. There's been lots of different integrated programs trialled in the literature. So, people combining different treatments together or addressing both through a CBT type method. But what the literature is finding is that these tend to be more effective than either substance use treatment or violence treatment alone. What's important to remember is that assessing and understanding the relationship between alcohol, drugs, and violence for every individual is important. And this is going to include their style of drinking or drug use, how much they're consuming, the nature of the violence. But it's important to remember that it may be that focusing on alcohol and drugs might only lead to effective outcomes if the alcohol and drugs are playing a key role in that violence. Now, we don't know that for sure, but that's something that we need to keep in mind. This might be most likely where it's sort of an emotionally driven type of IPV rather than the coercive and controlling type behaviours that Travis and Rochelle both touched on. So what's important is that we really understand how the alcohol and other drugs are playing a role in the violence and really try to get a sense of how then we can target treatment most effectively. A recent meta-analysis did say that if you combine both substance use and violence treatment, you are going to get a more effective result than either one in isolation. So I know I've said that, but I just want to kind of keep mentioning that because it's really important. So again, this is just sort of summarising what I have just spoken about. The Duluth style programs, there's no evidence in the literature for whether these work for people who have substance use problems and who use violence. And that's because they probably haven't been involved in these programs or it's not been addressed directly. So it's really hard to evaluate something when it's not a part of the program. I won't talk through the rest, but it's basically just, you'll see some of the literature supporting what I just spoke about. So I'll jump to the next slide. Thank you, Rochelle. So a couple of years ago, we conducted a study in collaboration with an alcohol and drug treatment organisation to try and find out about people who had engaged in intimate partner violence and what they felt were the most important treatment goals for their violent behaviour. So actually trying to get a bit of a consumer perspective on what would be really important to them and what they think the key issues are for their violence and their substance use. So we had 9 participants who are currently in treatment, and they identified 2 key themes for what they felt would be useful. The first of these was constructive communication. So most of the participants identified communication as being the most important skill that would help them. So many of them identified that the communication issues were the major instigator of the partner violence. whereby discordant communication strategies between partners or a lack of communication overall were identified as being the most problematic. They also noted that communication skills would really help them to, as a solution to the violence. So if they felt like they could express themselves, if they felt heard, this would stop the violence or the escalation of the conflict into violence. Because currently they were feeling like they weren't being heard, and so that was creating a frustration that was leading to violent behaviour. So skills like acknowledging the partner's perspective and discussing an issue rather than criticising, and being able to express their emotion to resolve the conflict might be important intervention targets for people who are using both substances and violence. The second thing that was identified was largely focused on emotions. So being able to identify and understand emotions that were being felt, being able to express and communicate these, and being able to manage big emotions without actually using substances to manage them. So one participant, for example, spoke about not being able to recognize they were angry while it was building, and that meant they would just snap. And they felt like if they could actually identify what was happening in their body, what was happening to them as it was building, that would help them and prevent them from escalating. And another participant spoke about keeping their emotions bottled up because they just didn't know how to express them. And again, that created that buildup of emotion that eventually turned into a snapping or an impulsive moment. So participants also talked about what they felt was important around group delivery, which was that they really liked from previous experience, or what they thought would be helpful was group programs where they could hold other people accountable and other people could hold them accountable for their behaviour. So they felt like challenging other people or being challenged was really helpful by people who actually understood them and what they were going through, and they could learn from other people about what worked and what didn't. So one participant spoke about how he had seen somebody else talk about using timeouts in their relationship, and they had found it really helpful. So he took that away and thought, maybe that's something that would work for me. Maybe we should try that. So there were skills being learnt as well through group programs. And another participant spoke about how important it would be to have ongoing programs. And what he meant by this was the ability to jump in and out of the program as needed. So sort of an ongoing program that didn't have necessarily a start and end date, but that anytime they felt like they needed some more support or some more skills, they could jump back into the program. The last thing I'll touch on is that participants felt it would be important to have their family or partner attend treatment with them. Now, again, this is a highly controversial area because there are issues around safety and safety planning and the roles in the relationship and the power imbalances, and we don't really know necessarily what's going on. But the people we spoke to did feel like this could be helpful to both learn skills to better communicate and understand each other a little bit better. But of course, safety would be the major consideration there. Next slide, please, Rochelle. Thank you. Okay, so it's important, I guess, in finishing up to remember the distinction between situational violence and coercive controlling violence. So often, but not always, substance-related family violence can be situational, potentially only occurring during intoxication and withdrawal, but again, not necessarily. And as Travis mentioned, there has been research that's shown that while gender attitudes are important, it's actually alcohol combined with these that has the greatest impact. And we know that situational violence requires a different response from a treatment perspective than coercive controlling violence. And this may play a part in why some of the programs have been not as effective for violence for those who use substances. And this also highlights the importance of responsivity, which is basically how well the program considers the event, or the treatment program considers the individual needs of the person. So of particular relevance to this cohort is the potential for a brain injury or acquired brain injury, traumatic brain injury, or neurocognitive impairment that could have arisen from the chronic or heavy substance use, could have come from experiences of violence as a child, which, as Trav mentioned, we know is very common for this group, or possibly through an accident or a medical condition. Regardless of the reason, any impairment in the brain or in the executive functioning is going to have an impact on aggressive behaviour and substance use, regardless of whether it occurs before or after any of those behaviours. So many studies have highlighted the associations between substance use and neurocognitive impairment. And some of those studies have actually specifically focused on those who use intimate partner violence. So for example, a recent review found that perpetrators of family and domestic violence present with high mental rigidity, low inhibition, poor processing speed, impaired verbal and attention skills, and trouble with abstract reasoning. They show impairments in working and long-term memory as well. And all of these factors are going to play a really important role in how somebody responds to treatment. So if somebody can't concentrate for long periods of time, if they have problems remembering new things, if they can't think through consequences, all of those things Dave discussed as well, they're going to have a lot of trouble with an intervention like CBT, for example, where all of those skills are required. So because of the likelihood of these impairments being present in those people who use substances and who use family and domestic violence, an important step going forward is to really screen for and understand any neurocognitive impairments, any concerns around their executive functioning that might impact on their behaviour, firstly, but also on their ability to respond to treatment. So what this means in terms of screening is that it's important to ensure that we're assessing both intimate partner violence and substance use together. And this should include assessing the relationship between the two, because this is where the complexity comes into play about what role is the substance use having, how do we understand that, and what other factors are playing a role. And it might be that modifying intervention programs or adapting intervention programs or having sort of pre-programs that really help to develop those executive functioning skills or that address those in treatment, that might have an impact on how somebody is able to engage with a treatment program and may result in more effective outcomes. A couple more things to touch on. I know I'm running out of time, my apologies. So I just want to touch on this idea that we're talking about substance use. So we know that there's going to be a time where someone might be sober, where they're intoxicated, and also when they're in withdrawal. And there's likely to be differing levels of violence associated with these. And this is where a risk assessment is going to be really important, trying to understand how someone behaves at different times. So during intoxication, the substance is affecting the brain, so the behaviour is likely to be impulsive and irrational and unpredictable, but the violence can also be more severe. Similarly, during withdrawal, there'll be potentially, depending on the drug, there'll be high levels of agitation, irritability and frustration, again, which can lead to aggressive and violent behaviour. So it's important in planning treatment, in planning case management, in risk assessment, that we're considering that there are these three kind of times where somebody might behave quite differently in terms of their violence, but all of those might be violent times, or maybe it's only one of the three or two of the three. So just to kind of wrap up what I've said, I guess what I'm hoping is really clear, and what we're all hoping is really clear, is that it's really complicated. And I think we all know that already. Careful assessment and consideration of all of the different factors that we know are involved in substance use and family violence is going to be really important, and being realistic about what a positive outcome might look like is really important. So substance use and aggression are often behaviours that the person is engaged in for a very long period of their life, maybe even most of their life or most of their adult life. So attending a 6 to 12 week program is probably not going to stop their substance use or their violent behaviour. So we need to be really realistic about what time frame we're expecting to see change, what outcomes we're expecting to see, and trying to encourage the person to continue on, rather than, discouraging them if they don't meet those goals or if they aren't able to abstain after a period of time. So really just trying to meet or kick little goals along the way, have some positive steps along the way to really encourage them to continue on. I'll pass back over to Rochelle now to finish up.
Thanks to the team again for coming along today. always learn a lot. As much as I work with you all the time, I always still learn things when you say all of this research again. So thank you, everyone. If anyone has any questions, obviously we're going to hang around and answer, the last 5 minutes. But there are contact details on the screen. We're always happy to chat about the research that we're conducting. So thank you again. Thanks for coming along.
Fantastic. Thank you, Rochelle and Ashley, David and Travis. And thank you also for hanging in there, because we do have a few questions that have come from those who've attended online, and I'll also come to the room as well. But I guess I'd just really like to say thank you for what you've done in a very comprehensive presentation there in a short period of time to take us through trends and prevalence, some of the neuroscience, also some of the explanatory models, as well as actually talking about interventions and right down to the components of those interventions. And some of the questions that we have from coming through are sort of wanting to expand on some of those areas. So what I'd like to do first, and I'll let you guys decide amongst yourselves as to who's the best to answer any particular topic that comes up. I might go to our room first here at Biala and just ask, because we have a lovely group of people here who are in attendance, if there's any questions from here. No, that's all right. If you do, just let us know as we go through. So I'll go through some of the questions that have come through. I guess we might start with what I hope is a fairly easy one first up. In one of the earlier slides, Rochelle, you were flagging up some of the data around where there were flags for illicit drugs and police-reported family domestic violence. A question came up about where's Queensland? Well, that wasn't in there, and I do hope the answer is that we're not collecting that data, because I'd be very, very sad if that was the case. But just wondering if there's any reason for that.
Look, from memory, we didn't present that data because the flag was either completely unreliable for some reason, or it just didn't exist in the system at the time. I think, again, from memory, it's a few years ago now, and like I've written a PhD since. I'm pretty sure that the system was actually being updated in the time that we received the data and then what it is now. So I'm pretty sure it is being flagged now in the system, but what we had was either completely unusable or not there. So sorry, Queensland, next time.
That's all right. There's a message there. We need to possibly get better on that. So thank you. I guess this is probably, just to be transparent, a question from me because of past professional life and what I've worked at. And I'm glad that it was really sort of brought into the presentation today that some of what are the common intervention models have relied very much on kind of static level type, I guess, sort of underpinnings or theoretical underpinnings. But am I right in what I'm hearing, and particularly with what Ashley was talking about and what Travis was talking about, that the models are becoming a lot more dynamic, kind of looking at an interplay of risk factors rather than these kind of broad underpinning societal or cultural themes about gender and power and those types of things? So a more sort of formulation driven approach to this sort of work or interventions?
Yeah, absolutely. So what's tending to happen, and particularly in this space, is that people have identified that the interventions just haven't been working. We've been using them for a really long time, using them for around 30 years, men's behaviour change programs, and we're just not seeing the outcomes that we should be seeing for something that's been used for so long. And so what we're now starting to see is that the newer models are starting to get more and more complex, I guess, more and more factors being considered. We're learning more all the time about what's playing a role. And I guess something that, Dave and I are pretty passionate about is that, the brain has a really big role to play here, and that we really need to be considering, in terms of any intervention, how any impairment in the brain is going to play a role in that. And we know this population is much more likely to have experienced some type of impairment in their brain from whatever reason. So I think, and there is research starting to come out now, most of it from Spain, that people who use violence in relationships do have a whole range of risk factors, all the way to the brain level, all the way to the neurotransmitter genetic level. Like there's a whole range. It's just getting more and more complicated. And I think that's really positive, because what it means is that we need individual plans. We need to know as much as we can about the person and their family and their relationship, so that we can really understand what the treatment targets need to be, and that might not be just one treatment.
Sure. Thank you. Thank you very much. And Ashley, while you're on the screen there, I might just jump to another sort of broad question here, which might be a big answer, or if you've got some guidance for us. Just, you mentioned about screening being very important, and obviously that's kind of, I guess, multi-spectrum type screening. Do you have any suggestions around particular screening tools or resources that would help in this way?
So I guess, I mean, a lot of organisations tend to have their own kind of tools that they prefer for alcohol and drug screening and family violence screening as well. So it is hard to say, because I know everybody sort of uses their own bits and pieces. And in Victoria, for example, we have Marum that we use for family violence. So we've got our own kind of set of tools. But in terms of the brain impairment and what's happening there, it is actually something that we're really focused on. I'm actually doing a fellowship on it at the moment, trying to identify a screening tool that we could use in this population to identify what's going on in the brain. Are there things that we need to consider when we're designing interventions or planning out an individual's course of treatment? So yeah, it is sort of, sorry, I didn't give a very helpful answer there.
No, that's all right. Well, we look forward to the publishing of that and could go well with it because that will be very informative. I guess in terms of, and also these questions, I think came up a bit earlier in the presentation and may have been answered, but I will put them out of courtesy and respect, that there was questions around that integrated approach. That seems to be, from what I think came later in the presentation, to be, as we know in a lot of areas of work, seems to be the kind of the one that has the juice in it. So would you have any examples of where integration is working well across, say, alcohol and drug or mental health, justice, all these areas that are often the touch points for the cohort of the clients or the people that are treated through these sorts of programs?
It's a really good question. I know in the past, a lot of this work has been done in silos. So it's been a case of, we'll deal with this part of it, the AOD part, and then we'll get somebody else to deal with the violence part, and somebody else will deal with the mental health part. And it's a bit of a referral game, and you lose them along the way because they've dropped out in between. So I'm not familiar with many services that kind of are integrating all three together. I know from some work I did with Odyssey House in Melbourne, they are running a relationship program there for people with substance use concerns. They're running a program around teaching skills for relationships and looking at the impacts that has on partner violence. So there are people starting to do work in this space, and I think over the next few years we will start to see some of those impacts and outcomes come to light, and we'll start to get a sense of the work that's happening and what can be really useful. But I think right now we're probably at the stage where a lot of people are starting to do that work, and so we don't really know as much about how it's working or what works really well. But what we do sort of know from the literature is that that approach is probably going to have the biggest outcome. And we know that from the mental health, AOD, the dual diagnosis literature. Like, we learned that in mental health 20 years ago, and we're still learning that lesson, I think, now when it comes to violence. So, I think this space has got a little bit of ground to make up, and that's because we've traditionally kind of been in that men's behaviour change space, and that's been comfortable, I think. And now we're starting to see that shift. So we'll start to see some more promising interventions coming out soon, I think.
Oh, for sure. And I think you answered that very well, given that we know that all the systemic kind of challenges we have with all of that discussion around integration. Yeah. It's probably time for you, Ashley, to share with your other colleagues. But
yes, please.
Just in case. So I guess probably coming back to some of the original data that was presented earlier on in the presentation, just a little bit of a question, and I think you might have answered this, Rochelle, in your section about, I think it was 4.66 times more higher, but how did illicit drug use, so I guess compare with alcohol in terms of increasing the risk of domestic and family violence?
Look, we certainly, from the police data, from the literature, we certainly know that they are compounding. And I do think you were correct about that stat. I'm not going to go back through my slides and find it. But what we do see in the police data is that if there's alcohol and illicit drugs, then we had the privilege of being able to track individuals in those data sets. When there were both involved, they would pop up again and again and again. So they were sometimes up to 27-time repeat offenders, and drugs and alcohol were sort of the common ground there.
Yeah, no, that's great. Thank you. And again, for anyone who wants to, because I think a lot of that data was in the slides, as you say there, Rochelle, and it is available. We've sent out the link in the chat. Also, if anyone coming onto our Insight webpage will be able to download the presentation if they want to watch this afterwards. I guess if you guys have got time, I know that we're 5 minutes over. I think hopefully there's one question. I think I've understood the intent of it, but to probably summarise, with the research that's gone on into the voices of the perpetrators around what's needed for treatment, have there been the voices of victims in the same way, balanced in the same way about what might be needed or helpful for treatment interventions for people who perpetrate domestic and family violence?
Yeah, it's a really good question. So we in that study focused particularly on perpetrators. So it, of course, is very one-sided, and what would be great would be to kind of do the other side and see what they say, because of course it is biased in that way that we're just asking the perpetrators like, what would help you, and they're just giving us their kind of answer. But I think it would be very valuable to get the other side, to get the victim side, their perspective on what they think would be useful, because that's going to play a really important role in terms of what they need and what they would like to see as well. So yeah, we didn't do that research, but it is certainly something that we would consider to be very important.
Sure, it might be one of those gaps at the moment, but thanks for being upfront about that. So, and just the final question here, how effective are treatment options when a person has, I know we've spoken about, like, say, cognitive issues, say mental health issues. Has there been any, and you may or may not know the answer to this, but any research into that side of things? And
look, off the top of my head, I don't know the kind of fine details around that. But my sense is that, there's a whole other factor, a whole other range of issues that are going to come along with any mental health concerns that are going to play a role. And it's going to depend on what the mental health concern is. So for things where violence is sort of a part of that mental health condition, like schizophrenia, for example, it's going to be a lot harder to sort of intervene in the traditional kind of way, because there's a whole other condition that, or behaviors that are associated with that need to be kind of addressed in some way. So it's going to depend, but my sense is that if you're not addressing a key factor in that person's life that's contributing to negative mood, negative affect, conflict in relationships in any way, problems around communication, then it's going to play a role in the violent behaviour, and it's going to be something that needs to be addressed. So I think, again, any factor that we can see that in some way is going to have a role to play in either substance use or violence, it's going to be important to intervene with that. And so that's should be a key treatment target as well.